Welcome to a new episode of Athero Voice, the official podcast of the Hellenic Atherosclerosis Society. I'm Fotis Barkas, Assistant Professor of Internal Medicine, Executive Member of the Hellenic Atherosclerosis Society, and the coordinator of the podcast. Today, we have the honor of hosting Professor Christos Lionis, an internationally recognized expert in primary care, public health, and health services research. He leads the Laboratory of Health and Society at the University of Crete and has contributed significantly to global initiatives in integrated care, preventive medicine, and community-based health interventions. Professor Lionis is also one of the contributing authors of the recently published clinical consensus statement of the European Society of Cardiology on mental health and cardiovascular disease, developed under the auspices of the EC Clinical Practice Guidelines Committee, a landmark document highlighting the vital but often underestimated link between mental health and cardiovascular outcomes. Our discussion today here in the 11th Pan-Hellenic Congress of our society today in Athens focuses on a crucial and timely topic, the contribution of mental health to the cardiovascular disease risk. Professor Lionis, welcome to Athero Voice. It's a pleasure to have you with us.
Thank you very much, Professor Barkas. I feel very privileged that's been in such a podcast that actually will discuss the very recently published document, an important document, revealing the strong association between mental health and cardiovascular disease. I'm privileged. Thank you.
So let's begin with the fundamentals. The consensus highlights the multidirectional interaction between mental health and cardiovascular disease, where psychological states influence cardiovascular risk and cardiovascular conditions impact mental health. So what are the key mechanisms by which stress, depression, anxiety, and other negative mental states increase cardiovascular risk?
Please allow me, before just a little bit exploring and guiding into underlying mechanism, just giving a more important concept that already developed in the consensus document, a focus on positive well-being. I think that is very important. This is the guidelines, the consensus discussing not only the negative determinants of mental health and cardiovascular impact, but also just giving more focus on positive determinants, including many dimensions of positive well-being, giving a more focus on joy satisfaction, job satisfaction, or sense of coherence, but also giving a more focus on the dimension of meaning in life. Exploring the evidence and supporting that people having this more optimistic dimension and having an understanding in a better way the meaning of life, just enjoying better health. Explaining also mechanisms that potentially having or accountable for this association, and giving a more focus on hyper responsiveness or exert protective CV effects via through a balanced physiology, including autonomic regulation, enhanced neuroendocrine functioning, and also inflammation, reduced inflammation. I think that is very, very important, just stressing the positive effect of some determinants of health, psychosocial determinants having a positive impact on cardiovascular. Now that's coming to your question, that's exploring mechanisms that are accountable for the association of negative determinants, means psychosocial determinants and cardiovascular. I'd like a little bit explaining a general integrated, if we can say, mechanism. I think that psychosocial determinants, that's we could discuss later on, giving more focus on specific determinants, and also just giving also attention to mental health conditions. I think that's the general pathway is that initially producing a biological stress response. This biological stress response is the start, the onset of inflammation, of autonomic dysregulation, an imbalance, and of course hormonal dysregulation. All of this triad could just lead to behavioral changes, and the final outcome is metabolic disturbances. I think all of this complex system that initiated by chronic stress and leading to many biological and psychological and mostly physiological disturbance that's leading to onset of CVD progression and development.
The document draws particular attention to psychosocial stressors: work strain, unemployment, socioeconomic hardship, discrimination, loneliness, and adverse childhood experiences. So how did these psychosocial and social determinants contribute to cardiovascular risk, and how can clinicians identify them early in routine care?
That is a very important question. First of all, despite we have many categorization, many attempts to categorize and group in all of these psychosocial determinants, I think that the consensus provides three major groups. The first group, as already you said, is work stress related and unemployment, when discussing together with the so-called socioeconomic determinants. The second group is determinants relevant to impaired social relationships. And the last one is more mental health conditions, which actually by the term mental health condition, we make a reference to depression, anxiety, and post-traumatic stress disorder. I think that is very important in giving more focus in the different, these three categories, despite the general physiological and pathophysiological background is common, but also there are some peculiar characteristics. I think that is important, of course, in stressing the impact of all of those determinants or groups to the progression and development of cardiovascular disease. In generally, they enhancing and augmenting the CVD risk, and of course having a strong association with morbidity and mortality. But I think that you're asking me a very important question: how healthcare professions in generally or psychocardio team could just consult and meet the visitors. I think that is very important. The consensus document is stressing a very important framework, means 6 principles named and entitled ACTIVE active. The active framework is a fantastic guidance. A means acknowledge the link between mental health and cardiovascular. C is a check the symptoms or the appearance of mental health conditions. T, tools, means validate questionnaires that's to be used in recognize symptoms and diagnosis. I means implement towards a person-centered strategy with an active involvement of a patient. A venture means try to change the traditional cardiovascular care. And E is evaluate the needs of the people, the needs of the visitors, trying to maximize a comprehensive and more holistic support.
Conditions such as depression, anxiety, and PTSD not only coexist with cardiovascular disease but actively worsen prognosis, reduce treatment adherence, and impact lifestyle behavior. Why should these mental health conditions now be viewed as independent cardiovascular risk factors, and what does this mean for our everyday clinical practice?
Yes, that is a difficult question. The consensus document actually revisit read and assess all evidence-based information available more on systematic reviews and meta-analysis. Always we agreed in discussing high in terms of quality evidence-based information in document to what extent those three major, if we can say, mental health condition could be considered as independent CVD risk factor. I think that's actually the concept of independent is quite difficult, but in generally the evidence we have in our hands and reported in this consensus document support that all of these three, depression and anxiety, most of focus or depression symptoms or anxiety symptoms, because professionals having in front of them not only well-defined diseases, but also symptoms relevant to depression and anxiety, considered as strong cardiovascular risk factors and compared, if we can say, to traditional risk factors, and also supporting that having a strong could be considered as a strong predictors of both morbidity, means cardiovascular events, and all-cause mortality. I think that the impact has been clearly defined in enhanced probability in development on progressing atherosclerosis and cardiovascular disease. But I'm thinking that now we started in discussing the mental health conditions as a predictors of cardiovascular disease before the appearance of cardiovascular, because we have in a lot of evidence and the consensus reported to what extent the coexistence mental health conditions or psychosocial other determinants plus cardiovascular disease, how to enhance the probability of further implications. The first part of this consensus paper and document discussed to what extent psychosocial determinants and mental health conditions could predict cardiovascular disease in all forms. I think that is very important and open a very big dialogue.
The consensus emphasizes that mental health symptoms are frequently overlooked in everyday clinical practice. Screening is often absent, inconsistent, or performed too late. So what are the practical recommendations for mental health screening in cardiovascular patients? When should it be done, by whom, and with which tools?
Thank you very much. That is a question that's addressing all health professionals or frontline professionals, not only cardiologists or general cardiologists, but included primary care practitioners and other medical disciplines. In general, recommended two approaches. The first is frontline physicians undertaking action of a very holistic clinical diagnostic interview. I think that is very, very important. A more comprehensive approach to the visitors. And the second is just to implement screening tools, validate screening tools by sample questionnaires, two items that the consensus document reported. And in the document included three questionnaires. The first was the Raleigh questions, the patient health questionnaire two items, and the generalized anxiety disorder also with the two items. I think that all of these three questionnaires having a very high sensitivity and specificity and recommended for an initial screening to having an understanding of the existence or the presence of one mental health disorder.
A central proposal of the document is the creation of the psychocardio team, integrating cardiologists with mental health professionals. How could such a model be implemented in real-world settings, particularly in Greece? And what role could primary care play in this integration?
Thank you very much. There was a fantastic diagram. It's a graphic representation of psychocardio team. And this is important, actually, Professor Barker said in discussing that it was a consensus comes from cardiologists now, and that's introducing also other disciplines. That is fantastic. Included primary care practitioners and general practitioners, but in generally frontline physicians, also addressing psychologists, psychiatrists, of course, social workers, and that's a little bit discussing about the synergy of interdisciplinary team. That's referring to us, and that's coming to the Greek condition, say how important is to see such integrated team in a very interdisciplinary. That's referring, of course, the need that we have in Greece in talking about the work in health teams, included all the disciplines, all, if we can say, medical specialties, but also allied professionals. I think that is a very clear message, spread not only in Europe, but also having indicating a very high relevance to our country.
It's also highlighted that the heavy burden of cardiovascular disease among individuals with severe mental illness, like, let's say, schizophrenia, bipolar disorder, severe recurrent depression, and the significant gaps in care they face. What steps are most urgent to improve cardiovascular prevention, diagnosis, and treatment for these highly vulnerable patients?
Yes, now that's a very sensitive and a very important subject. The consensus document reports that we needed more intervention now, effective intervention to that vulnerable group. Underlined that people with severe mental illness that are having poor motivation, lack of insight and cognitive impairment, and also underlined that they presented a limited participation in decision making. I think that's very clear. For all of those reasons, these people are not so-called adherent to the prevention, diagnostic, and treatment programs despite the consultation and despite the guidelines. That we needed in pay more attention to that group that actually having a very high probability in dying with a cardiovascular event in a higher degree in comparison with suicide. That the document concluded recommendation in three directions. The first direction always that's asking the frontline physicians, cardiologists, and general cardiologists just for a regular CV risk assessment. CV risk assessment independently of age. I think that's important, and that's before the prescription. Always recommended more to non-cardiologists that before prescribing any antipsychotic, it is very, very important in thinking about the probability and the risk for a cardiovascular event. The second direction of a guideline is very important in thinking a more holistic and more comprehensive management of cardiovascular disease in those type of people, and giving a more focus on intervention coming to modifiable risk factors, included weight gain, diabetes, hypertension, dyslipidemia, smoking, unhealthy diet, inactivity, and in general lifestyle. I think that how difficult now is talking about all of these severe mental ill people, talking about a change in the lifestyle. But all of this is so important, and we are aware that obesity is a very high determinant and enhancing the probability for progression of atherosclerosis and cardiovascular disease. And the third direction, which is so very important, is to optimize pharmacotherapy. It is very, very important and recommended just selecting monotherapy and using also medicators that have no side effects life that's leading to obesity and again weight, but also just having or enhancing the probability for CV risk. It is also important always, that is a recommendation to frontline physicians, checking and consider the potential drugs interaction, but also just also checking, that is a key message, always checking about the adherence to medication. That's also a very high important issue in people with severe mental illness.
Beyond pharmacology, evidence-based interventions such as cardiac rehabilitation, psychological therapies, stress management, and caregiver support play a vital role. Which of these interventions do you consider most effective and most immediately applicable in everyday clinical practice?
Yes, I think that rehabilitation, cardiac rehabilitation, and in general is so very important. But also it's very important in just a little bit focusing on specific groups, that are very not only suffering but having a very high probability in developing a serious CV event, and also dying from cardiovascular disease. And the document making a specific referral to people with a frailty. Frailty is a cardiac frailty is so very important, and still we're having some intervention. We're saying that intervention to frail people are quite essentially, and that's encouraging cardiologists and general practitioners, frontline physicians, in focusing with the frailty. A second category of a vulnerable group where just a cardiac rehabilitation is so important is people so-called with advanced age. Older people in generally having a high probability in just developing cardiovascular disease. And a consensus document introducing a lot of guidance and recommendation how to approach people with advanced age, and also just mentioning to what extent intervention could just be benefit on both mental health conditions and disorders and cardiovascular disease outcomes. In general, of course, I supported that those type of interventions are quite effective in alleviate the mental health disorder related burden. Less effective in terms of cardiovascular outcomes, but despite all of this restriction or not so beneficial in cardiovascular outcomes, in generally the document introducing and discussing the importance in developing intervention in vulnerable groups, and especially in frailty in people with advanced age. Another important group that consensus report document show light, it was caregivers. This, Professor Barkas, this is a very, very important issue. Since even in Greece, I'm afraid that we will not just pay so much attention to caregivers, especially to caregivers that dedicate so much time with cardiovascular patients, especially with heart failure, patients with cardiac frailty, that actually suffering and having an enhanced CVD risk, and also a high probability in developing a form of cardiovascular disease. That giving and paying attention and giving a specific guidance, not only just in reducing the burden to caregivers themselves, or indirectly enhancing and improving the quality of care to the cardiac patients, but also just reducing the high cost allocated to healthcare services. I think that's for all of those reasons, the document dedicates many lines with the focusing on caregivers. I think that's also is very relevant to Greece, that our attention to caregivers, not only for cardiac patients, is one of the high priorities.
And before we close, a forward-looking question. What do you believe are the most important research needs and also future challenges in the field of mental health and cardiovascular disease over the next decade?
I have already identified three directions. We needed further evidence and, of course, more research to the concept of positive well-being. Positive well-being, as you are aware, is an issue that mostly addressed by psychologists or relevant therapists. I think that is also a key issue for us as a medical doctors also. That's giving more light based on research and evidence-based to positive mental health, developing better tools, more cultural adapted to the Greek setting. I think that is very important. The third direction is giving more focus on patients with severe mental illness and cardiovascular disease. I think that is both accountability for cardiologists, but also mental health practitioners. I think that this vulnerable group deserves more attention, even for research and also for design of more effective, better in terms of outcome interventions. And the third is more focus on organization of healthcare services. We needed to increase more focus on integration of care. Integrated care is a big issue coming across not only Greece, Europe, and outside, across world. We needed more organizational and behavior-based models, and we needed to check effectiveness and efficiency. Thank you very much.
Professor Lionis, thank you for this insightful and thought-provoking discussion. The ESC consensus and your contribution to it, along with your long-standing work in primary care and public health, offer a clear and much-needed perspective on the integration of mental and cardiovascular health. Thank you for joining us today here in our Congress also.
Truly, I feel privileged just having such a chance in reporting a very big consensus report developed by interdisciplinary team under the auspices, that's important to underline, of a European Society of Cardiology with the support of European Association of Psychologists and European Association of Psychiatrists.
And to everyone listening, thank you for joining us. Stay tuned for the next episode of Athero Voice, where we continue to explore new dimensions in cardiovascular prevention and holistic patient care.